Hello and welcome to this symposium on retinal imaging at the cellular level. Today we will hear from 7 clinical research teams about the capabilities for examining the retina at the cellular and microvascular scale. So we are very excited to hear about what all these teams are doing with adaptive optics retinal imaging, and we will be also happy to present some new features that are enhancing the capabilities of the RTX1 camera. So today we have with us 3 wonderful chairs who are experts in ophthalmology and who will animate the discussions. So first is Kiyoko Gocho. She is an ophthalmologist who currently works as a researcher at Institut de la Vision and 15 National Eye Hospital in Paris. She is also visiting associate professor of ophthalmology at Nippon Medical School and a visiting ophthalmologist in Kobe Eye Center in Japan. So do you have more to say about your work?
Thank you very much for kind introduction. So now I'm working in Paris, 15 Hospital. So I've been using the RTX1 and the new devices and the TFI. So today there is a several talk from our colleagues. So thank you very much for kind invitations.
Thank you. And our second chair is Thomas Theelen. He is an ophthalmologist at Radboud University Medical Center in Nijmegen in the Netherlands. Can you tell us more about what you are doing in Nijmegen?
Yes, thank you, Marine, for the kind introduction. I'm doing research with AO on inherited retinal diseases and age-related macular degeneration and on central serous chororetinopathy. And we are combining these research points together with other imaging modalities to learn more about adaptive optics and also try to do definitions on what you see on the photoreceptor layer besides the photoreceptors, and to normalize nomenclature and so on. So it's very thrilling to work with adaptive optics in this. These
Thank you. So, and our third chair today is Chiara Eandi. She is an ophthalmologist at the Jules Gaudin Ophthalmic Hospital in Switzerland and also working at the University of Torino in Italy. How do you want to welcome the audience today?
So thank you, Marine and Imaginize for the kind invitation. Yes, I started using the RTX1 while I was in Paris, as you know, working with a group of Michel Pack. And now I'm dividing my time in academic appointment in Torino and research appointment in Lausanne, where we have the RTX1 with the TFI module. So I'm very excited about this symposium, and we will have a good discussion. Thank you.
Thank you. So as you can see from the program that I'm displaying on screen right now, we have quite a great diversity of topics that we will be hearing on today. So I'm sure you're all excited to start. So Kiyoko, do you want to open session 1?
Thank you, Marine. So as a first talk, so I'd like to introduce Midori Yamamoto. She is this orthoptist in the Kobe Eye Hospital, and she's using the RTX1 more than 10 years in Kobe Eye Hospital. So she's the one taking all the images from the patient and working with the Professor Mandai. There are several clinical trials and many studies.
So we can move on to the next speaker that will be introduced by Thomas.
Yeah, thank you. I'm happy to introduce Jeroen Pas from our lab in Nijmegen, who is a PhD student on Stargardt disease, and he is investigating the progression of Stargardt disease with several imaging modalities. And since last year, we have also collected a lot of data on adaptive optics in Stargardt disease, and I'm happy to ask Jeroen to share with us the results of this imaging project.
Thank you for the introduction. Can you all see my screen right now?
Yes.
All right, great. So if I, yeah, now is the second slide. All right. So thank you for the introduction, Thomas. As you already said, I'm investigating Stargardt disease in the Radboud UMC. And the aim of that research is to find new biomarkers that we can use for clinical studies in Stargardt disease. Because currently, right now, with new clinical trials upcoming, we want to use the best biomarkers for clinical trials because we want to prove that the drug works. One of those new potential biomarkers is the adaptive optics. So Stargardt has a broad range of phenotypic variety, and you can see this on these images. Stargardt has a wide spectrum from early onset Stargardt patients who develop with atrophy at the center of the macula at a young age to late onset patients who have an interesting phenomenon, which is called foveal sparing. And that means that the fovea of those patients is spared, surrounded by atrophy, till a very long time in the disease progress. And what I want to show you is that we made images of that foveal sparing in our Stargardt cohort. And let's walk through a few cases. So this is the example image that I showed. And what you can see very clearly here right now is the border of the foveal sparing right here, surrounded by the atrophy, which you can see this atrophy because of the vessels in the choroid that you can see. So we followed up a few patients. First one is a patient with age of onset of symptoms at 41. And you can see right here on the autofluorescence image, foveal sparing. But when we image that with the RTX1, you can see it much better. You can see right here the borders of the foveal sparing. And what's also interesting is that in a normal patient's eye, or in a normal people's eye, you can't see any photoreceptors in the center. But in this patient, probably because of the Stargardt disease, because of swelling of the photoreceptors, you can see a few in the middle. It's surrounded by atrophy. You can recognize that with hyperreflective clumps. And when we go into follow-up mode, this is the first image at baseline, and here's a visual acuity of 0.87. When we follow it up, you can see in 6 months that you can see the foveal sparing line receding. So you can see very much in detail how the fovea declines while visual acuity stays the same. In 12 months, it even recedes more. Right here in 18 months, you can see there's a very big difference between the baseline measurement and the measurements that was taken after 18 months. Well, the visual acuity still was the same. So for a biomarker of progression, visual acuity doesn't perform well, it keeps stable. While the foveal sparing measured on the RTX1 really shows the decline of the disease. What's also interesting is that you can see the hyperreflective clumps moving. So if you focus right here on the clumps, you can see that they, for every visit, they are not in the same place, they move. So probably this hypothesis that it's something like macrophages that are cleaning up the remnants of the photoreceptors. We don't know it for sure. Maybe you have input what it is, but we think it's something like that. When we go to another case of a patient with foveal sparing, right here, you can see already on the montage, very good, where the foveal sparing is, right here in the middle. And when we go into the close-up, you can see it as well, and you can see again photoreceptors in the center, where normally no photoreceptors are visible in a healthy person. So in this patient, you cannot see much progression, which is really interesting because at the previous one, you saw really clearly the fovea decreasing. In this one, it keeps stable, but visual acuity declines from 0.12 to 0.06. So there are patients that are declining in the visual acuity, but are staying stable in their foveal sparing. And probably it's because this patient already fixates outside the foveal sparing. We also did microperimetry in these patients, and what you can see is that at the baseline visits, there was a little retinal sensitivity left in the foveal sparing, but at 12 months, no retinal sensitivity was left. So probably you can still see the anatomy of these photoreceptors on this image, but they aren't functioning anymore. The last case for today is a 61-year-old patient, also with foveal sparing. But on the fundus autofluorescence, you can't very clearly see the borders of the foveal sparing. But when you're going to look with the RTX1, you can see much more clear where the foveal sparing is at and where atrophy is. So this means the measurement is much more precise than the autofluorescence, which is currently the gold standard of atrophy measurements. I only have 6 months follow-up of these patients, and you can see there's a little decline of the foveal sparing right here and right here, which you can't see on the autofluorescence because everything is dark right there. So for take-home points, in addition to cone density measurements, you can image more features using the RTX1. For example, foveal sparing area. And this has potential as a biomarker in new clinical studies. But before we can really use it in clinical studies, we need to assess more of these patients in more extensive multimodal natural history studies to be sure that we really know what we're measuring. Thank you.
So thank you for those already 2 super interesting presentations. I want to remind the audience that if they do have questions to ask to the speakers, please use the Q&A of the Zoom to type in your questions. And now, yes, it's for Chiara.
Yes. So now it's my pleasure to introduce Melanie Kempf. She's optometry and psychophysics. She works as research assistant in inherited retinal diseases at the University Eye Hospital and Center for Rare Eye Diseases at the University of Tübingen in Germany. So, and as we have just heard, the RTX1 is used in many observational and interventional trials in inherited retinal diseases to detect the smallest changes in retinal structure. And furthermore, RTX1 is used in the daily clinic for inherited diseases, especially in patients where the diagnosis or the pathology is quite unclear. So Melanie now, she's going to present us her research on adaptive optics retinal imaging in patients with Usher syndrome. Melanie, please.
Thank you so much. Thank you for the introduction. So I just want to give you a short insight in our previous publication about the adaptive optics retinal imaging in patients with Usher syndrome. And we used the RTX1 to quantify the photoreceptor mosaic in the macula in retinitis pigmentosa associated with the Usher syndrome. And additionally, we compared and correlated the results with our clinical ophthalmological diagnostics that are used in our clinical routine for inherited retinal dystrophies. And especially with a view to further studies, observational trials or interventional trials, we are especially interested in if we can use the AO camera as a biomarker and if we can correlate the results with our functional tests. So for our study, we had 10 patients with a genetically confirmed RP due to mutations in MYO7A and USH2A. And all 10 patients underwent a complete comprehensive ophthalmological examination, including standard diagnostics such as the BCVA, kinetic visual field testing, and retinal imaging, like the OCT, the fundus autofluorescence, and color fundus photography. And additionally, a full field ERG and multifocal ERG was recorded, and the adaptive optics imaging with the RTX1 was acquired. and a montage covering the central area of approximately 8 to 8 degrees was combined from single images. And additionally, we analyzed the cone density. So to come to our results, the patients were between 16 and 60 years old. And so there was a huge heterogeneous state. So they were really different, the patients. The best corrected visual acuity ranged from 2400 to 2020. And one eye only had light perception. And in all patients, we could observe the typical fundus changes like the RPE changes with pigmentations, narrow vessels, pale optic discs. However, due to the time limitation, I will just jump directly to the AO images. So we could obtain the AO images in all the patients. And in almost all eyes, the AO demonstrated a cone mosaic pattern with dark patchy areas like hyperreflective, blurred cone-like structures. And in two not so progressed patients, the cone mosaic appeared mostly preserved. And one patient was really progressed. Here we couldn't obtain a photoreceptor mosaic. However, single residual cones were detectable and we could see them really nicely. And on the next slide, we can see an example of one patient where the progression was slower, and in patient 7 on the right side, we can see a really progressed patient. And we analyzed the cone density at the fovea and at each 0.5 degree horizontally and vertically from 1 to 4 degree eccentricity. And on the slide, you can see the positions where we measured the cone density. And we could observe that, of course, in the patients which were not so progressed, the cone density was higher. And in the progressed patients, the cone density was lower. And unfortunately, in 2 patients, we couldn't quantify the cone density because the quality was too bad. But in the others, it was measurable. Then the results of our analysis of the cone density are shown here in the graph or in this figure, and along with the normative data from Legras from 2018, who also analyzed the cone density with the RTX1 in a healthy population. And of course, compared to healthy individuals, the cone density was severely reduced. And furthermore, a comparison with the SD OCT, the thinning of the outer nuclear layer and a disruption of the inner and outer segment line revealed a relation to the reduction in the cell density. So here we could also observe a correlation to the OCT. And then we compared our results from the cone density with our functional tests. We compared the amplitude of the multifocal ERG with the cone density. And to analyze this in more detail, we compared the cone density within the central 3 degrees with the central 3 degrees of the response of the multifocal ERG. And the comparison revealed a statistically significant difference between the mean cone density of the eyes with a measurable multifocal ERG and with eyes without a measurable multifocal ERG. However, we couldn't confirm that a higher cone density leads automatically to a higher amplitude in the multifocal ERG.
So it's time to conclude, sorry.
Yeah, no, it's okay. And as the last point, we had we compared it also to our kinetic visual field. Here we couldn't see a correlation, which also leads us to the conclusion. So it is possible to visualize the central cones, which is for us important. So when there is a loss in the central area, you can detect the single cones. And we were, however, expecting a much higher cone density in the central areas. So we were expecting that centrally there is a higher cone density even when the visual acuity is lower. And as a last point, that we could correlate the amplitude of the multifocal ERG to the lower cone density, which is for us important for our studies, so that we can correlate our functional tests to the imaging. So I hope I could give you a quick insight into the results.
Thank you. Thank you, Melanie. Very interesting study. So maybe I can start with one question, if you don't mind. So you show a lot of images. I mean, your acquisition protocol seems to be with many images. So how much time does it take for you to image one eye with a Usher?
It depends a little bit. So in this study we had only 5 images. Maybe it takes 10 minutes. It depends a little bit on the patients.
Okay, so also when a patient is not fixating very well.
Yeah. Normally
because
it
you
works
included
quite
patients with a poor vision as well.
Yeah.
Okay.
But it worked quite well. So we used the big cross of the AO, so it was possible. Yeah.
Okay, so that's a good advice for our colleagues.
There's a question and comment from someone in the audience. Very beautiful images in these 3 presentations. Thank you for the nice insights on the human retinal imaging with RTX1. I'm a mouse eye phenotyper, and I'm curious, how does the mouse retina imaging looking like? Do you have any experience with using the RTX1 on rodents? I don't think so.
I don't have any experience, so someone has it.
So I can answer for Imaginize. We have experience in using AO imaging in rats, not in mouse yet. And we will be happy to share about it maybe after this symposium. So we will keep exchanging by email. Thank you.
Perhaps I may ask a joint question for Jeroen and for Melanie. And you both work on inherited retinal diseases and phenotyping of these diseases. And we know that there are upcoming therapies of these diseases. And I'd be curious about your vision on, first of all, how to identify pathological cones in RP or in Stargardt. And the second one is, what is the additional value of adaptive optics in concert with other imaging modalities?
That's a good question, a hard one. I can explain or tell you one example. So we also use it for our RPE 65 patients, which underwent the Luxturna therapy. And here we could really observe after the therapy, so after the detachment, we could see that the positions of the cones was after the therapy different, and that it is after 2 weeks, it got more stable, and after 4 weeks, it normally stays, which we couldn't obtain in any other examination. So that is one example where we can really see, okay, there's a huge benefit. Nevertheless, we are sometimes struggling with the limitations. So our patients have often a bad visual acuity, so the fixation is bad, or they have a cataract, then it's also hard. But when we can acquire images, we have really often a huge benefit.
To answer my part of the question about Stargardt disease, about the pathological cones, I think it's really hard to say when cones are pathological, but you can turn it around. You can see when cones are healthy, if they have the nice structure, the mosaic that you can see in healthy patients with smaller cones, the more near you are to the fovea, then I think you can conclude that the cones are healthy. And if you can't see them like that, you can't say whether they are unhealthy or they are healthy, but you have bad image quality. That's still one of the drawbacks of the RDX1, I think. But to counter that, you can combine it with microperimetry. And you can check the functionality of the cones in a certain region with just placing microperimetry stimuli on it and see whether these are normal or not. For the clinical trial, the additional value of the RDX1, I think you can use it for cone measurements on places where the cones are at baseline already good visible. So if you don't have good visibility, then I don't think you can use it then for clinical trials. But you can use it as well for qualitative assessment of pictures. So like I showed in the presentation about foveal sparing, you can image borders of atrophy and have a more precise measurement of the atrophy growth compared to fundus autofluorescence, for example.
Do you have any comment for Midori, or how about you? Or is it better to go to the next, Marin?
We can take one more question.
Yes, actually, I want to add something about the pathological cases. So we usually like when there is a nicely photoreceptor packed, we don't see it in the foveal cones, but like Usher's or the other IRDs, often we see the foveal cones. So it means there is some reason like decreasing of the density of the photoreceptor. So it's not so easy to compare because in the healthy case we cannot measure it, but like 2-degree density, so we can very nicely compare in there are several papers about it. Just for addition.
A question for Midori. What was the goal of looking at this transplanted RP cell for several years? I think you said 4 years.
Yes, and the density is stable for 4 years, so it means that the transplanted RP cells is safely, as
it's
it is
stable.
Yes,
yeah.
it's safety tests, so it doesn't change to the cancer, or they don't, make it worse. So it's stable as RPE. It is very important point for the
Thank
future
you.
treatment.
Thank you.
Okay, so thank you all for this very insightful first session with great images and example of cases. It's time to move on to the next session. So today we have with us 2 wonderful experts that will be discussing about standardization and good practices for AO studies. So the first panelist, Michel Pack. He is professor of ophthalmology at 15 National Eye Hospital and leader of the Clinical Investigation Center. And so among many clinical research projects that are focused on the medical applications of high-resolution retinal imaging. He, among other things, pioneered the use of RTX1 camera in AMD and also in conditions that affect retinal vessels, such as arterial hypertension, but not only. So he will be discussing today about suggested protocols for AO imaging for vascular studies. And our second panelist is Danilo Andrade de Jesus from Rotterdam. So he is assistant professor and the principal investigator at the iImage Analysis Group, which is a joint collaboration between Erasmus MC and Rotterdam Eye Hospital. And so he has many years of experience, and he specialized in image processing and AI applied to ophthalmology. And so he is leading the AO Vision project, which has for aim to develop new methods for the analysis of AO images in inherited retinal disease in order to develop new biomarkers. And so he will talk today about suggestion of protocols for examining IRD patients that have come from these projects. So I want to let them do share their insight right now. So it will be first Michel.
Thank you, Marine. Thank you for the invitation. Okay, so hello everybody. So I've been interested in imaging in particular of vessels using adaptive optics, but the first thing that appears the first problem that is needed to cope with is the fact that vessels show a high diversity of diameters and disposition. So it's obtaining a single measure. We'll go back to the very first one. And in fact, every patient has his own disposition of vessels, even if they are common patterns. And by adaptive optics, we have access to the fine structure of the artery, and in particular, the arterial wall, which is shown between the white arrows here. And this gives the opportunity to extract some biomarkers, such as the wall-to-domain ratio, which is interesting to follow up a hypertensive patient. But the question is where to measure the wall-to-domain ratio. Should it be on the largest vessel, on the smallest vessel? And we've been spending quite some time to try to standardize this approach. And first of all, I'll show you our current protocol to image the vessels. We usually do superimposing acquisition, superimposed by 2 degrees in order for the montaging software to be efficient, and concentrating first on the superior arcade, as you saw here on this example. So we end up with a nice viewing of the arteries by montaging 10 to 15 images. And from which you can extract some morphometric parameters as shown here in the lower bottom image. But the point is, it's not easy to characterize the entire microvascular pathway. So we have to decide, in order to perform large-scale studies, to identify, we need to identify what we would call a reference zone, in which for every subject, the wall-to-domain ratio will be considered. So we first started, as in most studies, to use the temporal artery out of the disc. So the diameter is larger, so there is less effect of blur. And next slide, can you? Okay. But we prefer now to use what I call the reference zone, which is at the vertical of the fovea. In fact, every subject has 2 horizontal artery, or let's say 90% of the population. One over and one under the fovea. So when you draw a straight line, a vertical line from the fovea, the first horizontal vessel is, in most cases, an artery. And this is where we measure the wall-to-domain ratio. Next slide. And the measurement and the reference zone are less affected by interoperative variability, require less cooperation by the patient. We just have to ask him to look up. It enables to use older version of the RTX1 camera. You don't necessarily need to use a wide field camera. And they're less affected by disc edema, which may be a problem in severely hypertensive patients. And also it's more convenient to evaluate the neurovascular response following flicker. The problem is that the vessels are smaller, so you may be more affected by blur. But you, in each patient, you have 4 reference zones. If one reference zone has 2 small vessels, you can choose the other 3. Do I still have time? I'm on time, Marine?
You still have 1 minute.
Super. This is how to extract the reference zone from a montaging. It's usually where you see the nerve fiber layer starting to arch to the inferior zone. And so this is an illustration here of the reference zone in the subject. And we've been performing such measures in large-scale studies. Next slide, I think it's the last one. Yeah. And so you prefer to stop here, Marine, as you mentioned?
Yes, I think we can keep the figure for later. So do you want to add something in conclusion?
The conclusion, I think that this protocol opened the way to standardize a protocol that will enable to compare large-scale studies and maybe even perform pharmacological studies in a more reproducible way, and then pave the way toward larger acceptation of the use of the RTX1 in particular in cardiovascular diseases.
Thank you very much, Michel, for sharing these methodological updates with us today. So if there are questions, again, you can type them in the Q&A. And now we are going to hear from Danilo about also protocols of acquisition in IRDs.
Okay, so you can see my screen, right?
Yes.
All right. Thank you for the nice introduction, Marine. So it's a pleasure to be here and to also to listen to the different talks of this amazing panel. So and I'm very happy also to have the opportunity to share the results that we have from Erasmus MC and the Rotterdam Eye Hospital. So as you clearly said at the very beginning, our work is focused on the imaging of IRDs, so the AO Vision project. And when we started this project, we wanted to have like a specific protocol, and it was quite difficult to design something that could cover all kind of IRDs, because as we already saw in the presentations before, so depending on the type of IRD, so the early stage of the disease and the advanced stage of the disease can be very different. So what we decided to do in our work is to focus on the most common type, so retinitis pigmentosa, and then to develop our methods based on this specific protocol. Okay, so in a nutshell, so this is pretty much how the protocol looks like. So we start with a macula-centered image to see the locus of fixation of the patient. And then we acquire 2 rows. And these 2 rows towards the periphery and towards the temporal side. So towards the periphery, because we want to detect early changes, and in this case, retinitis pigmentosa, so the changes start from the periphery to the center. And we choose the temporal side, because then in this kind of way, so we also avoid as much as possible the shadows of the vessels. And then we acquire 2 extra rows at the around the fovea. And this is also because of the characteristics of the disease. So in advanced stage, so what we see is like an atrophic ring. And this is something that we also want to keep track when we are doing imaging of these patients. So pretty much this is how the montage looks like. So in total, we acquired 21 images. So it takes 10 minutes per eye. And I must say now with the new software update of the RTX1, so it's very easy to acquire this protocol, because it just, you select one image, you acquire it, press next, get another image, press next, get another one. So it's very good for the technicians in terms of learning rate. But it's also very good for the patients, because it's less time on the acquisition itself. And then another advantage of for instance, of this protocol is that we also have, then we cover different kind of regions. So we can cover the fovea, we can cover the parafovea, the perifovea, but we can also reach the periphery. And once again, so this is important because if there are any kind of early changes, we should expect to see those here in the periphery. And then, for instance, with the protocol, then if you just want to look at specific region, like between the fovea and the parafovea, we can, for instance, get like metrics from it, like the cone density. And this is something that we have been doing and that Luisa Sanchez is going to present later on in the symposium as well. So this was how it looks like for healthy control. And this is how then the montage looks for someone that has a retinitis pigmentosa. So you can see that the result of the montage is still very robust. And this is because of the 2 degrees overlap that we also do between images, which is very important. Another thing that we can also see in this image is that you will have kind of different patterns in the image as well. So depending on which region you are, and this will also depend which stage of the retinitis pigmentosa the patient is as well. And something that you can also pay attention here is that we acquired these 2 extra rows is the trophic ring, which is very clear here. And with analysis like this, so you can also then isolate part of the ring and, for instance, keep track of other patterns that we see in these images besides like the cone density. So I think this is the biggest advantage of this protocol because it requires pretty much information from early stages, but also advanced stages, and it allows us to step back and to look at other patterns that we see also on these images, because in these kind of images, there is much more than just looking at cone density, and this is something that we should, keep working in the upcoming months and years. That's it in a nutshell.
Thank you very much. So I'm sure that, again, there will be questions from our chairs, maybe the other speakers, and we have a bit more than, we have 13 minutes to discuss more on that. So feel free to ask questions.
So maybe I can start. Very nice images, Danilo. So do you have a specific protocol for other retinal diseases like AMD?
That's a very good question. No, the answer is simply no. We don't have it at the moment. There are really nice works in literature focused on AMD as well. So I think what is missing actually is that convergence of the standardization. So we need to have like more people agreeing on saying, okay, let's say have this kind of protocol, let's start using this specific protocol and then compare results. So this is pretty much what we all want to try to do with this one specifically for retinitis pigmentosa. So then there is a standard protocol that everyone can use and then facilitate the comparison of results across centers.
But maybe Michel might want to also answer on Chiara's question, because I know that work is being done at 1520 on AMD, so maybe there are some guidelines, if no real, standard protocols on how to examine those patients.
Yeah, the issue of examining AMD is much more complex than examining vascular diseases. Just by the fact that in vessel we have one plane, and in AMD you have multiple plane drusen's and multiple features. So I think we cannot think of a unique protocol for all AMD patients. It needs to be segmented by staging, early, intermediary, late. And so the most easiest to do is early geographic atrophy, so late AMD with atrophic lesion, IROA, for which adaptive optics can document very finely the contours of the atrophy and document with high precision the progression. So that's quite easy. It's there's in most cases no real issue about focus. But for all the rest, not to mention even neurovascular disease, for which I don't think there is currently protocol for that. You have to identify specific area. And I think the second area in which AMD can be examined with a standard protocol is very early drusen, the very small drusens, because of course in large drusen you don't really need RTX1 to see a large drusen. The OCT does the job. But we've shown, our group has shown that the smallest drusen, let's say beyond 100 microns, are often very difficult or even not detectable by OCT, while they are detectable by RTX1, especially using a new protocol we recently published. It's a gaze-dependent imaging. It consists of just doing the same image of an area, but with slightly different field of views. It's not Stargardt, it's something different. It's more positional than directional. And by subtracting the difference between these two images, you highlight very nicely the drusens. And this is quite easy to implement in the new version of a software. Now it's implemented as a standard protocol. And I think that's a second interesting application of the RTX1 to early stages of AMD. Otherwise, we do research program on other features such as pigment dispersion, for instance, and growth of drusens, but they're not yet a standard protocol I think we can apply, but we're working on it. Given the importance of pharma trials in the field, I think it's worth pursuing the efforts.
Michel, there is a question from the audience. Thank you very much for your wonderful presentation, Professor Pak. Mydriatics are known vasoactive agents. In regard to static vessel imaging, besides the great resolution, RTX1 had the huge advantage of not requiring mydriatics. For functional analysis, however, mydriatics are required to counteract the meiosis induced by the flickering light. Do you believe that these agents could have a confounding effect? And if so, do you think that there's a solution to overcome this potential effect? Thank you very much. Thank you for the question.
Excellent question and very difficult to answer. Well, I think the basic caution is not to use neosinephrine, for instance, epinephrine. I think that's the most important thing to do. Then we dilate the patient using tropicamide, and as was mentioned, since flickering light uses light, visible light, so there is inevitably a meiosis. So we of course we don't need full dilation, so minimizing the potential effect of mydriatics, we should avoid full dilation. But we're quite confident that there is not really an effect of, well, probably a minor effect. However, we did not quantify it because the flicker response is quite reproducible from one subject to another and over time. So I would expect from the heterogenic interaction that there will be some variability. We think it's reasonably reproducible, especially if since we're now using the reference zone, the span of difference of inter-examination difference has diminished. But I think a dedicated study would be necessary to definitely assess this point.
Thank you.
I have a question to Danielo. I like this algorithm very much, and I would be interested in the follow-up examinations of patients using your protocol. Did you test this already a short-term and long-term follow-ups, and what about the reliability of reproducing cone positions on certain locations?
Yeah, that's a very good question. So at the Erasmus, we started this study 2 years ago, so we don't have too much follow-up data at the moment. So we are now calling the patients after 1 year. So that's what we do in this specific study. So we just have a few patients at the moment. We didn't have the opportunity to analyze the data itself. But what I can tell is that, for instance, the kind of patients that we receive here at Erasmus MC, they're already in advanced stage. So it's more likely that we will not be looking at, for instance, at like the photoreceptors itself, but we will be looking at other patterns and how these patterns change. So what I can say is that there is still a need to classify or create standards towards the patterns that we see in these images as well. I know, for instance, there is a nice paper from the group of Tübingen from 2 years ago. So where they, for instance, try to give this tentative of creating a new classification for new patterns like puffy cones, sheeted pattern, the ring as well. So I think there is a need for this, and this is pretty much what we are going to try to do. From, for instance, AI point of view, it's difficult, for instance, to classify a model or a supervised model if you don't know exactly, if the clinicians don't have yet, or there is no standards for which patterns exist. And what we are trying to do at the moment is working towards unsupervised classification models and see how can we just identify in an unsupervised way, for instance, these different kind of patterns. And yeah, and that's what we're going to be doing with the follow-up. I have a question actually for Michelle. Nice presentation, as always. I was curious because you mentioned that, like, with the new protocol that you suggest, so imaging just above the fovea, so there is less interoperator variability. And I was curious if that change or less interoperator variability is just because we are imaging above the fovea, or just because, for instance, in the previous versions of the RTX1, there was not the protocol follow-up, because now with the new protocol, let's say the new protocol software or update, we can just like image exactly some specific regions.
Yeah, I totally agree that now the issue of reproducibility within the same department, using the same machine, indeed, is without doubt improved. The reproducibility is much better using this improving the software. But I was thinking of between centers, if you want to compare your results in multi-center study, and it's much easier if you start by the first examination to examine always the same area. And so this is a step forward, having more uniform results and lessening the choice by the operator of the specific zone to examine. And it's also because it's probably it's less eccentric, so you have more precision in the imaging, and less confused by the optic nerve fibers. So I think there is another advantage, but the drawback is that the vessels are smaller. So indeed, it may create some problem. If the focusing is not perfect, you may end up with a little bit of blur. So yeah.
So Michelle, may I do an additional question on this? So vessels are smaller. I think it's harder to look at the vessel walls and look at pericytes and so on. So are similar analysis possible in these vessels compared to the large vessels around the optic disc?
Well, we think that it's even better for the flicker testing, because when you do the flicker, the response is higher in smaller vessels and higher when you eliminate the macula. So what we call the reference zone seems a better target for improving neurovascular coupling. So since we're using that for neurovascular coupling, why not use it for every possible measure? Another advantage is that when you do the flicker protocol, you also do 3 measures of the same area, so you have a better reproducibility of you obtain a Waldman ratio naturally without any additional imaging procedure. So that's why we decided finally to use that as a routine procedure. But I agree that if you have a little bit of cataract, then you go to larger vessel will give you an information. So in aging subject, we've been working a lot on Alzheimer's patients, so it may have some drawbacks. So that's why I think we should stay pragmatic. So we try to use the reference zone if it does not work. So we go to a larger vessel to capture any possible information to have at least one number to end up. But that's also where it is the issue of normalization of the Waldman ratio relative to the size of the vessel, because we know that in normal eyes, the Waldman ratio diminishes in larger vessels. So we need also normative data to correct for the size of the vessel, the wall-to-lane ratio you obtain to have, and that will further decrease the inter-subject variability and so increase the performance in clinical trials.
So thank you very much, everyone, for this really interesting discussions. There is not more question from the audience right now, but I'm sure we could be discussing more about the topics of standardization. But I think we can move on to the next topic, and actually it's a kind of a perfect transition because I will be now like saying a few words about what is new in RTX1, some new features that are already available, and I will explain a bit more about what Danilo and Michel have talked about this new software and the protocol features. So thank you very much for sharing the guidelines, and now I want to show what we talk about when we say protocols in the software. So with the new software, you will be able to choose from a list of protocols, and like Danilo showed in his presentation, the protocols will, it's a preset of acquisitions that will guide the user for executing a series of images in the examination of the patient. So instead of setting, each parameter, the gaze, location, and maybe other parameters for each acquisitions, it's all preset. You take your first image, and after you push next, and all the settings will be done, and the operator can really focus on getting high quality, good images, and there is less room for mistakes in terms of forgetting some part of the acquisition protocol and things like that. So this is what is coming with the new software. And also we have made it like for getting the montage out of the several images. It's now really easily done with the dual align first-in-class montage algorithms that can be automatically executed, and in the end you can cover areas like that are maybe more than or almost 3 mm by 3 mm square with the high detailed of image that is enabled by adaptive optics. And so this protocol workflow feature in the RTX1, of course, it will help also for the longitudinal AO studies. So that was one question from Danilo to Michel just before. So similarly, you will be able to choose a follow-up protocol, which will load basically a group of previous acquisitions that have been done in that particular patient. So here it's an example that shows about following the vessels, but it can also be like some macular area or following the edge of a lesion. And similarly as before, it will just guide the operator to acquire the same images while showing the images from the previous visit. This way, you can be sure to capture again the same area of the retina, even if there have been some change in fixation of the patient, for example. And then once you have acquired those follow-up images, there is the auto-registration of baseline and images of the next visits that enable to really analyze the exact same areas in the images and detect really minute changes in lesions or in measurements. And again, you can also in one click get the montage from the different visits, and it's also possible with dual align software to really align the images and the montage together. So that was about explaining a little bit what these protocols that have been cited are about. And I can also now explain more a little bit about the TFI module. So if you remember the first presentation today, Midori Yamamoto from Kobe, she has showed some images of the RPE layer that were obtained using RTX1 TFI modality. So recently in RTX1, we have added this TFI module, which is an addition to the hardware, and it adds a new illumination mode, which is transscleral illumination. So this illumination, it sends the light to the retina with oblique rays through the sclera. And the effect is that it reveals the RPE layer that is under the photoreceptor layer, and RPE is usually hidden by the photoreceptors. So with this oblique light, we can reach it. And so here we are looking at a healthy eye. We see that the photoreceptors are there with the standard illumination through the pupil. And when we use the TFI illumination, we can observe, as Midori showed also earlier, this pattern that is characteristic of RPE cells. In pathology, there is a pigment redistribution also that can be observed. And if you want to hear more about this, please stay until the next session of this symposium, because Céline Chaumet from 15 will be showing some case reports that have used TFI in pathology. And so you see, we have also, so we have enhanced the usability to make AO studies really possible also in clinical trials and through different centers, and to help really with going through this standardization of the procedures. And we have also added some new modalities. So this TFI imaging. So in terms of making it really applicable in more large-scale studies, what is new with TFI, because TFI module, the hardware, has been available since last year. What is new now is that the acquisition procedure is simple, and it captures both images, photoreceptor and a TFI image, simultaneously, providing twice more information on retinal structure than with the same number of acquisitions. And the other new features that have been added, so Michel has mentioned it a few times in his talk, it's about flicker stimulation. So in addition to showing really detailed views of the vessels and enabling very precise measurements of the morphometry of the vessels, there have been a need for more functional assessments. So we have been requested for introducing flicker stimulation in the RTX1. The request was to enable the assessment of neurovascular response, neurovascular coupling, by leveraging the level of precision of adaptive optics. So the RTX1, with the new software, it can deliver this kind of flickering stimuli to the eye that is imaged. And at the end of the stimulation, the image is captured automatically. And also with the high precision alignment between images, then it's possible to make very precise measurements between images without flicker and with flicker. And that's how the early results that Michel was talking about could be obtained. And so if you want to hear more about RTX1 imaging using flicker stimulation, stay also for session 2, because Rui Bernardes from Coimbra will explain us what they are doing with this in Coimbra. So that's all for what I wanted to explain today about new features on RTX1. If you have questions, don't hesitate to ask. Okay, well, if there is no question, I don't see question in the Q&A. And if there is no questions from the speakers, there is a quick poll for the audience. So you should be seeing a poll window on your screen. So there is just 2 questions plus the last field is for comments. So please feel free to let us know. The first question is to know more actually about what is of interest for you. So today in the program, there is a lot of different topics that have been or will be addressed. So we are curious to know what are the trends and what kind of topics we might want to address again in the next event, maybe. And the second question is if you want to know more about the RTX1 device or about the new features that have been introduced on the device, let us know. If you want to discuss with Imaginize, if you make a request through this poll, we will contact you to schedule some call with you. And also we will be exhibiting the RTX1 at a conference in December in Florence. It's the ICOOR/Floretina event. We will have a booth, and if you plan to attend that event and if you would like to see the device in real operation, we can of course organize for that. So I will just let it go a little bit more. We are on time for the program, and yeah, I'm checking if there are new questions. Checking for any raised hands. No raised hands either. Maybe it's because my explanations were clear. One question. So there is one question from the audience. Sorry for the perhaps naive question. Would the flickering mode also require additional hardware or just software? So it's not a naive question, and actually it requires new software for existing RTX1 devices. For most of them, it's compatible hardware-wise, and it's new software. But we have to look at on a case-to-case basis, because some units might need some hardware upgrading to be compatible with this functionality. Okay, so I see the time, and now it's time to move on to session 2. So I will close the poll. I hope everyone who wanted to answer did answer. I close it now, and I will leave our chairs to introduce the speakers of session 2.
Okay, thank you, Marine. So it's my pleasure to introduce next speaker of session 2 is Eva de Oliveira Figueiredo. Eva has a PhD in neuroscience, and she's now working at Jules Gonin Hospital in Lausanne as a clinical research associate. After her PhD, she realized that she wanted to have more clinical feeling, and so she joined my research group here in Lausanne, and she learned how to use all the different imaging modalities, and in particular the RTX1. And now today she is presenting a case of acute macular neuroretinopathy with follow-up. Eva, it's to you.
Yes, thank you very much for the kind introduction. So I will share my screen. Okay. So I will shortly present the case of acute macular neuroretinopathy that we have seen here at the hospital. And this is the history of this case, a 37-year-old woman without any previous medical or ocular history, that she was only taking a contraceptive pill. She presented at the ER complaining of bilateral constant paracentral visual field scotoma that was present for the last 2 weeks. And concerning the recent anamnesis, she actually had a rally car accident, but without any neurological sequelae. And right after, she contracted COVID and she was in isolation for 10 days. Concerning the ophthalmological exam, actually her visual acuity was 1.25 for the right eye, 1.6 for the left. At the slit lamp examination, there were no signs of inflammation and no media opacities, as you can see, and IOP was normal. On the dilated fundus ocular examination, only an alteration of the macular reflex was present, and we will see it better here at the OCT examination. Here for the left eye, you can see in the multicolor image a large perifoveal dark lesion here that we better see in the ER reflectance image, this hyperreflective lesion here. And in the OCT scans, we can see the disruption of retinal layers that you can clearly see here. From the ellipsoid zone to the outer nuclear layer. So these clinical and OCT signs could be referred to an acute macular neuroretinopathy, as it was first described in 1975 from Boss and Deutman, as you can see here. And since we observed the disruption of the photoreceptors, of course, we decided to apply adaptive optics, and we used the RTX1 to image this area that you can see here. And here you can observe that we can see normal photoreceptors and like the pathological area here that corresponds very well to the lesion seen in the ER image. And this dashed line delimitates the intact photoreceptor area from the disrupted one that you can actually better see here in this zoomed image. Same for the RP, but here there were no big apparent changes. And we come to the follow-up after 11 months, where you can see that there was a partial restoring of the disrupted sites. In the multicolor image, we can see again the large perifoveal lesion, but that is less darker now, and you can see it better in the ER reflectance image that is less dark and smaller actually. And at the OCT scan, we can see the recovery of the layers involved that we imaged again with RTX1. And here you can see the area that we imaged. And again, for the same area as before, you can see that we have a large number of photoreceptor compares to 1 year before. And here again, the dashed lines show you the recovered photoreceptors. And for the RP, again, very quickly, no big changes for the same area. And here to resume and show you just the recovery of the photoreceptors, you can see that after 1 year, we have in the same area a large amount of visible and good, let's say, healthy photoreceptors. So in the context of this case, we can conclude that RTX1 allows to visualize and confirm PR alterations, also for the RP, the same thing, and we can follow up pathological areas. And of course,
in the context of such cases, further research is needed to better understand the use of RTX1 in clinical practice, and today we have seen some. And I would like to thank all the medical retina unit and all the people involved in this, and thank you for your attention.
So thank you very much for this really well presented case with really clear, we could really clearly understand what the images were showing. So I want to remind to the audience that we will take the questions at the end of this session. So there will be 4 presentations in this session. So don't hesitate to write them in the Q&A, and I will let Kiyoko introduce the next presentation.
Thank you. So now I'd like to introduce the Louis Bernardeschi. So he has PhD and he's working as assistant professor at the Faculty of Medicine, University of Coimbra, Portugal. So his research is aimed to elucidate missing links between brain and retinal pathology, so including Alzheimer's disease and diabetes. So he uses various retinal imaging technique to try identifying changes on the central nervous system. So with RTX1, he's using flicker stimulation. So he investigated neurovascular response and the possible crosstalk between the retinas. So today he will present about the neurovascular coupling. So please start.
Okay, so thank you so much for the kind introduction and for ImagineEyes to giving the opportunity. I'm trying to share. Okay, you can see it.
Yes, okay.
Okay, thank you. So the topic is a bit different from the previous one, and I don't have that many nice images to show. Nevertheless, what we are trying to figure out is if there is indeed an existing crosstalk mechanism between the human retinas, and in particular are looking for if there is an active and working crosstalk mechanisms. Why is that? Well, it is really well documented in several mammals, including non-human primates, and therefore it will be quite puzzling that we are left out of having this mechanism. It was never documented or actually searched for in humans, and let alone in working conditions. And therefore, we thought that we would take advantage of this very nice machine, the RTX1, and our collaboration with Michel Tac in Paris and Deli Cabrera in Miami. And we thought that it would be nice to having a try. And the idea is quite simple indeed. So what we have considered is that perhaps we can have an stimulation in one eye, and if there is a working crosstalk mechanism, definitely we should look for some response, neurovascular response in the non-stimulated eye. For that, we have developed this apparatus that you can see here that attached to the RTX1. There is no intervention directly in the machine. Everything is built on the outside. And as you can see here in this configuration, we can get image from the left eye of a patient or a subject, while we have a stimulation on the right eye. So taking the image on the left while we have stimulation on the right. And that's it. And if there is any potential link, either brain-mediated or non-mediated, that is a direct connection, there should be some effect. So the rationale is, if there is no effect, there is no, at least not possible to identify. If there is, at least there is a very strong possibility of having a working one. So the protocol is quite simple. So keep in mind that we are always imaging the same eye. So the protocol is quite simple. We have established these 4 steps. So we take several and 3 basal images, so prior to any stimulus. Then we have stimulus in one eye, and we keep imaging the same non-stimulated eye. That's what we call contralateral, as you can see here. And we always repeat that 3 times. Then we have a 5 minutes interval, so to allow the system to recover to the basal states. And we repeat the process now, having the 3 sets of basal scans again. But now we have also, after stimulating the eye being imaged. So that's what we call ipsilateral stimulation. So the protocol is quite simple. And we have used or imaged a set of controls, 22 health controls and 7 type 1 diabetic patients with no signs of diabetic retinopathy whatsoever. And for flickers, frequency and the duration is very much standard. So location-wise, we were interested to be as close as possible to the fovea, so you can get an idea of where the locations are. So we have a fundus photograph, and we are imaging in this case in this region, in this case in here. And instead of having just a single measure, because we are just going to measure the vessel lumen, so the vessel width. And instead of having a single location or just 2 locations, we thought that we would segment, and we have done it manually. We have segment an artery segment, like you can see in here, and therefore you can compute the average width of the segment. So it's a much more stronger measure than just a single location. But that's for simple to have very strong data and not very specific or location specific dependence. So as for the raw data, that's what is being shown here. So we have all the cases shown here in this plot. So the bars on in blue are the basal ones. So the ones on the left are the basal before any stimulus. The green is the measures after the contralateral stimulation. And then we took 5 minutes of interval, and we have taken another 3 scans for the basal and then the ipsilateral. So blues show basals, and the green after contralateral stimulation, and the red after ipsilateral stimulation. And we have computed the change in the percentage-wise, the change in the vascular diameter. You can.
So sorry, there is only 1 minute left in the time, so I want to tell you.
Sorry. Okay. So we can compute the average or very standard change in the vascular width. So we have for the ipsilateral and for controls, we have achieved what is currently disclosed in the literature. And for exactly the same for diabetes, we have a not so high level of response. But what is interesting is that indeed we could find a contralateral response that, as you can see here. Indeed, there are some responses that are not by chance, and indeed you can even find those with a different pattern for the diabetic cases. To make sure that we were on the safe side, we have set 4 criteria to make sure that what we are measuring is actually depending on stimulation. And for that, after following those criteria that allow to ignore the ones that not show the expected behavior, we still have for the LD control group that 45% of those indeed show contralateral response, and you can compare those to the ipsilateral one. And for the diabetic patients, we can even found a completely different pattern of response. So in a nutshell, indeed, we could show that indeed we can say, or this data supports that a functional construct mechanism exists, and apparently, but the figures are still small. Apparently, this might be impaired in some diseases. That's what we think, and at least for these numbers, for type 1 diabetes, it is indeed the case because the pattern is the distance from the control group. That's all. Thank you so much.
Thank you, Rui.
Yeah, thank you.
For Thomas to, yeah, go
The
ahead.
next speaker, it's my pleasure to introduce Luisa Sanchez-Brea from Rotterdam Erasmus MC, and she's assistant professor and principal investigator of eye images analysis group there, and she's working in automated processing and adaptive optics image data since several years, and other modalities like OCT, OCTA, and she is in a research team together with Danielle, we heard earlier, and she is also principal investigator managing the AO Vision project. And a recent output of this project presented by ARVO is an AI model for automatic detection of cones in RTX1 images, and I'm happy to hear about these automatic photoreceptor detection now. Thank you.
Thank you. Thank you for the nice presentation. Let me share my screen.
Your camera is off too.
Oh, how did this happen? Okay, sorry. I think you can see my screen, right?
Yes, okay.
All right. Well, first, thank you. Thank you for the opportunity of for presenting indeed our work in this team. On automatic photoreceptor detection in adaptive optics imaging. So, okay, so indeed, as Thomas also mentioned, now I'm a colleague also of Danilo, and he already presented during the panel the protocol that we use, which goes basically for 4 degrees nasal to 12 temporal, so it covers different eccentricities and quite a large area of the retina. So we are, as you see, pretty much interested in the photoreceptor layer. And as we are all familiar with, this layer allows us to identify individual cells within these AO images. But our first problem for this project was that, okay, we have a lot of information, so how can we use this information effectively? How can we quantify some metrics in this data? So what we have done is to explore, develop, and validate automatic approaches for analyzing cone photoreceptor in these images, so that we can work with different eccentricities and different image sizes. But first, our first problem was to define basically what is a cell on these images, right? Because we have to have a ground truth or annotate what are our target cones. So what we did was to define a small and easy to communicate criteria that is basically we annotate the cells that follow these 3 principles, that they have this round shape, they show an intensity peak compared with the surrounding tissue, and they have a similar size and spacing, so a similar distribution, so to say, to neighboring structures. And this is, of course, for healthy-looking mosaic. That's what we will be working with. And we had 4 experts from 3 universities, so not only in Rotterdam, but also in other centers annotating these images. And once we had these labels, we could train a deep learning model, which is basically an artificial intelligence technique that receives the input images and the data labeled by our experts, and trains in order to then be able to produce the detection of the cells in data that the model has never seen, so in new image. And before going towards the results of our model, just let me make a brief mention of what are the intra and inter agreement for these different eccentricities. So we see that comparing our 4 graders, both between themselves and between 2 observations and among themselves, we are around 0.8 of F1 score, so it's quite a reasonable agreement. It drops a bit for the intergrader in the 7 to 10 degree eccentricity, but these are images that are more challenging indeed, even for the human observers, because you still you start to see rods, for example. And then if we compare with model performance, so the model versus the manual annotations, we can see that we are in quite a similar range of values. So we are also on the same level that the intra-grader agreement. But now let's see also a few examples of what we observe when we apply the model to our images. We have here one example of application to an image that is closer to the fovea, so to 2 degrees, and an image that is more towards the periphery. And we can see, especially if I zoom in, we can see the differences in the mosaic and how the model is able to capture quite well those different images. And what we can do is also use this data to generate density maps. So basically, we use these detected spots to compute average values of density on different parts of the retina. And we can color code these densities by purple to blue, this is the lowest densities, towards red, which is the higher density. And we can apply this, of course, also in the mosaics, not only in the individual images. But in the montages, we have a few things that we need to note. The first one is obviously that we see in these images an apparent dropout of cells around the fovea. And since this is a healthy control, this is, of course, not true that you have less cells in the fovea, but this is just the limitation of the technology. We have, well, with the resolution of the RTX1, we cannot really isolate individual photoreceptors in a healthy fovea. So then, of course, the model can also not really identify cells that are not there, that are not visible there. And the second aspect is that we have in this photoreceptor layer vascular shadows. And these vascular shadows basically block the light and does not allow to also identify photoreceptors there. However, there is a boundary where the model still identifies some photoreceptors, but we want to basically exclude the shadow area from the analysis because we have some uncertainty here and we just want to remove potential bias. So what we did was to also apply AI to do this shadow removal. We labeled also a data set by different clinical experts, and we train an automatic system that can generate these vascular shadow areas in the images. And here I don't divide by eccentricity because we segment the whole images and not so dependent on the area. But you can see that the intergrader agreement is maybe surprisingly lower, but not so surprising because you can see that the edges of the shadows are really, really blurry. So it's a challenge to mark what the edge really is. And the model still is able to find to match the target accuracy that we want for this case. And yeah, in summary, when we combine all of these steps, like the detection, the density map, and the removal of the vascular shadows, we have a model that kind of matches the human grader, so the intra-expert agreement, and it reduces our need for manual correction. Then it can be used more automatically. We enable a large-scale analysis because we can analyze the complete image, and we can tackle a variety of eccentricities, not just the target measurement area, but also different areas in the retina in one go.
Thank you very much, Luisa. We have to move on to the last presentation.
Yes, thank you.
So I'd like to present the last presentation from our colleagues. So Céline Chaumet, she's a certified orthoptist, and she's working at the Clinical Investigation Center at the 15 National Eye Hospital Paris with Professor Pax James. So she is the one of the super heavy user of the Retix1, the expert user of the Retix1. So she examined more than maybe, I don't know, several thousand or 10,000 patients. And she was always help us to train the other new Retix1 users and participate in the numbers of many studies and helping us to make some of the other protocols too. So at 15, she also used the Retix1 TFI. So today she will present about the transscleral imaging in early AMD. Please.
You're still mute, Céline. Ton micro.
Voilà.
Ouais.
C'est bon. Mince, du coup, j'ai perdu. Ah oui, elle est là. Okay, so thank you very much for inviting me here. So today I would like to present our AMD cases and about a new imaging modality based on adaptive optic fundus camera RTX1 with a transscleral illumination system. Here on the picture, you see on the left side the standard adaptive optics RTX1 we have in our site too. And on the right side, the adaptive optics transscleral imaging modality RTX1 TFI, we got it also. The transscleral modality allows observation of the retinal pigment epithelium, RPE. Here with the RTX1 TFI, on the left side, you can see the RPE of ELC case of 29-year-old person. And on the right side, the geographic atrophy case of the 78-year-old person here. This patient was already operated of cataract. So the blur is not about the cataract. Please note that in the geography atrophy retina, there are more hyperreflectance and hyperreflectance areas. We see the larger RPE cells in this image. The hypothesis would be in the lack of RPE cells, others on larger to fill the gaps. A step further in the evolution of EMD is the presence of hyperpigmentation. This is the presence of melanin clumps within the outside of the RPE, within or outside of the RPE. We can see here that it defines a stage called the intermediary AMD. Three entities can be observed. The hyperreflective foci located in the outer retina. Here we can see the thickened RPE here, and the feature in adaptive optics that we call hyperreflective clamps. We can see here. So next case, here is an example of hyperreflective foci seen by the RTX1 and TFI. Overall, it is interesting to note that the TFI often more sensitive to the presence of the hyperpigmentation. This is possibly because the specular reflectance of melanin clumps may overcome their absorption. Here you can see we don't see very well the melanin, but we can see here better with the TFI. On the bottom, in the slide, this is the follow-up of case of hyperreflective foci, showing that they are made of several hyporeflective clamps, and also shows their evolution over the time. Here is an example of thickened RPE. Note here the hyperreflectivity by OCT and the presence of the posterior shadowing and of hyperfluorescence in the infrared. Hyperreflective in infrared autofluorescent is known as melanin. Comparing RTX1 and TFI performance, once again, is clearly in favor of the TFI system and nicely matches with NIRF. Indeed, it is easier to identify the correspondence of hyperfluorescence areas in NIRF with the TFI than with the RTX1. So, and to conclude, I will say at first glance, we will not think of the TFI system, but rather the standard system of EMD, because it is mainly a disease of the photoreceptors. But ultimately, the TFI shows us a lot of things. So thank you for your attention. That's all.
Thank you very much for all the presentations in this session. So we can take 8 minutes to address questions if the chairs have questions or if participants want to type in the Q&A. So there is no question in the Q&A yet. So,
okay, so I have
please, the speakers can go ahead.
May I start?
Yes.
I was interested by the case of acute macular neuroretinopathy, the AMNR case that's shown by I forgot her name. It's
Eva. Eva Michel.
I was wondering, well, it's AMNR is a quite complex disease, but there is a feature that may explain the fundus aspect, this dark aspect, or the non-visibility of photoreceptor. In the photoreceptor misalignment, I mean, some photoreceptors are not only shortened, but also do not point toward the center of the pupil. So maybe I missed it, and you mentioned it in your presentation. But we found that counting of photoreceptor is done more efficiently if you consider imaging done at several angles of viewing. Have you tried that, or have you data about that?
No, actually, we haven't tried from different viewing sites. As you said, we just tried the normal images. But actually, yeah, it's clearly like the outer segments are missing or are atrophic. I don't know. We cannot see any photoreceptor with the AO imaging with RTX1. As you clearly saw, there's this quite different in the pattern of the pathological photoreceptors and the normal ones. But we haven't tried another modality for the imaging.
So no, Michel, we haven't, but yeah, this is a good point. I think we will do next time. And that
in my experience, the AMNRs have traces of AMNR for months, even years. So next time you see the patient, you can do the directional imaging, and probably you'll find that indeed photoreceptors are there, but they're not visible because they're not pointing toward the center of the.
Yeah, thank you. We will try that.
Would like to ask a question to Luisa. I'm wondering about the overlapping frames we have analyzed in a mosaic segmentation. And my experience is that if you look at photoreceptors in the center of a frame and in the periphery of a frame, there is somewhat difference in the appearance and in the identification capabilities of the photoreceptor. So Did you find any differences in overlapping frames in the same areas of photoreceptors in your segmentation software?
So to be fair, we haven't conducted this experiment, but you are absolutely right. Like we don't, and actually also linking to what Michelle was just commenting on, that we have for some papers, for example, using a reduced measurement area, measure like in 4 different images overlapping in order to have to ensure that we capture all the information, because it's true, and also it's true that in the center of the images and the periphery, you may have different I don't know if call it quality, but it's more like for example in especially in my case, for example, as a high myope, I have a bit of blurriness in the edges of my AO data. So that's certainly something that we need to investigate, and I will expect that there are differences, yes.
So I see that there is a question from the Q&A. So the question is there a role for AO in diabetic retinopathy? So I don't know if the speakers from that session have something to say, or if in the total panel, I'm sure that there is.
I think because Rui presented, the neurovascular coupling. So do you have any response?
Well, yes, not in the standard way, but as I have shown, apparently there is a different pattern in the neurovascular coupling. So this mechanism might be compromised. I have no experience whatsoever in using the standard way of ipsilateral imaging, so I cannot answer regarding that viewpoint. But yes, so from that mechanism, so it means that the mechanism might be compromised. And but as I mentioned, we only have 7 cases up to now. There are more on the way, so very soon we'll have much more nice database. So that's my current understanding.
Thank you very much. Is there one more question? Maybe time for just one question.
It's not a question, it was an answer about diabetic retinopathy.
Okay, go ahead.
When we've been examining the capillaries using the RTX1 in diabetic patient, and indeed we can reveal some interesting phenotypes beyond the microaneurysms. For instance, hard exudates are very nicely seen by adaptive optics, and this gives a nice insight into the distribution of these hard exudates. You can see small hard exudates, let's say 10 or 20 micron wide. It have been published by Meyer-Salé a couple of years ago. And it's maybe an interesting biomarker of early rupture of the blood retinal barrier, but also of the distribution of edema and where do these micro exudates go in the retina. So it's complex often because we have to take care about the edema may blur the vision, and the thickness of the retina varies, so the focus also may vary. So it's not really easy, but if you take time to focus on this area of interest, then we extract interesting information, and we are actually working on that.
Thank you very much. So we have again a few questions for the audience before we close this event. So once again, just scroll down to answer all the questions. And in the meantime, yes, I want to thank very much the 3 chairs and all the panelists and speakers for sharing what they are doing with adaptive optics retinal imaging, and also the insight and vision about what might be done also in the future with it. And I will let Nicolas say some concluding words for this event.
Okay, thank you all. And as Marine said at the beginning, there was a great diversity of topics, and several advances of AO imaging have clearly emerged from this symposium. So it's great to see that the technology is being used in an increased number of assessments. It started with photoreceptors, but now it's RP cells, atrophic border expansion, retinal vessel microstructure, and neurovascular response, as we saw today. For me, it's also very interesting that several teams like the groups in Rotterdam and Paris have endeavored to define standard imaging protocols and share guidelines with the community. It's an important progress and it should benefit all of us. So as a manufacturer, we want to support these efforts with improvements in the technology, and I hope you will find that it's reflected in our new software for RTX1 that Marianne introduced. And now to conclude, I want to express gratitude to the chairpersons, Chiara, Kiyoko, and Thomas, for their precious help in organizing this symposium. And many thanks to the panelists and speakers who have shared experience and their most recent findings, and to everyone in the audience for attending these events. So see you next time, and we will keep you posted about our webinars. Thank you very much.